All right. All right. Good afternoon, everybody. Good afternoon, Wednesday, this beautiful Wednesday afternoon. Welcome and thank you so much for joining us. So for those who are not aware, February is American Heart Association Month, Awareness Month, as well as Black History Month. So what a good way to have an event like this, looking at the statistics that we have regarding high blood pressure and heart health. So welcome again. So on this call, we have a few guests as well as the CECJ staff. Thank you so much for joining us. So I'm looking forward to having a very informative session here, as well as taking in questions. We have a lot of information to share as well as questions that we were able to crowdsource. So keep those questions coming, put the questions in the chat. For those who are new to the Zoom platform, utilize the chat room as much as possible. So let's get started here. Let me introduce the this host, the hosting organization. This is Community Engagement and Consultation Group, a nonprofit organization based in the Capital Region area, state of Maryland. We have been in existence for about 6 years now. And we're excited to be here and doing this. And again, for those who are new to this to these events, every Wednesday we have events on different areas of focus. And that's from 12 to 1 p.m. So you can always look us up on our website, which is www.ce-cg. Again, that's www.ce-cg.org. All right, let's get started. All right. So let me just give you an overview of the blood pressure statistics here. So nearly 1 in 2 adults, US adults, that's 116 million people, have high blood pressure. And about 3 in 4 US adults have high blood pressure, which is 92 million people, and they are not aware, and it's not under control. High blood pressure rates varies by race and ethnicity. And there are over 500,000 US deaths each year that are linked to high blood pressure. And because high blood pressure affects so many Americans and is a key risk factor for heart disease and stroke, it's one of our nation's costliest health conditions. And high blood pressure is common and a dangerous condition and a key factor for heart disease and stroke, which is also common and dangerous condition to heart disease and stroke. So with all due, let me introduce our presenter here, Dr. Davis. Dr. Davis has over 10 years of experience at demonstrating her abilities to partner with multi-dimensional organizations in a most effective way. She is also in the area of health and wellness, and she's based in South Carolina. So the way this is going to be presented to you is a conversation-like style. So we welcome you to be engaged, ask every question that you may have that's on your mind. So let's get into it. So Dr. Davis, so high blood pressure, let's get started. So why is it a concern today?
Well, Dr. Anita, thank you guys for having me. I'm so excited to be here. As Dr. Anita stated, my name is TQ Davis, and I currently work for one of the largest healthcare systems in South Carolina, where I work with hypertensive patients quite often. So I currently oversee our hypertension management program, where we get to see a lot of patients who suffer from high blood pressure, who are on the borderline of being hypertensive. And for those patients who this might be their first time of actually getting their blood pressure read, because as Dr. Anita stated, a lot of community members do not know that they do have hypertension. And then unfortunately, a lot of people realize they have hypertension when they have a stroke. So we all know that hypertension is the most preventable risk factor for a stroke. And so when you have a stroke, that's a whole different beast within itself. So the question is, why is hypertension referred to the silent killer? So a lot of chronic illnesses have different type of side effects, right? Have different type of complications. With like diabetes, you might feel thirsty sometimes. If you have asthma, you feel the wheezing in your lungs. But with hypertension, it's one of those things where there's no type of symptoms. So that's why it's undetected quite often, unless you actually go to a physician, or if you happen to have a blood pressure monitor at your house. And then the caveat to that, you guys, is the fact that it fluctuates, right? So a lot of people might be considered hypertensive one day, right? And then they take it again within the next 20 minutes, their blood pressure could seem normal. So that's the thing about blood pressure. It's really good that you understand those numbers. And then also just take it on a regular basis. I usually tell my patients to take it on a regular basis at the same time, so that there's a little bit of consistency, and also with the same blood pressure monitor, because like your scale, like when we jump on different scales, you might weigh 115 on one scale, you go to the gym, you might weigh 125, and you're just like, what in the world? But the reality is, of course, any type of machine does have calibrations, and then there's room for different readings. So the idea of the fact that it's silent, right? We talked about the quietness of it, because you really can't feel having hypertension. You don't feel it until it gets to the phases of when it becomes a killer. I don't like to use the word killer, but the reality is, when hypertension is undetected, that's when we're prone to have a stroke or an aneurysm. Because if you think about the physiological component of blood pressure, right? You have your arterial walls, they're just like a tube. And then when your blood is always pumping, so that's called the pressure on there, right? And so sometimes your walls could be working extremely hard, putting a lot more pressure on those arterial walls, where they get a little bit harder. And then as they get harder, what happens? The blood flow may slow down. It could slow down. And when your blood flow slows down, it's called pooling, right? So when that blood pools, it gets a little thicker. And when it gets thicker, it can form a clot. And so if that clot can travel anywhere in your body, and then that could cause a stroke. So it's very, very, and I tell patients and I tell community members that it's very important that we understand, one, what blood pressure is, two, how do you check your blood pressure, and three, the long-term effects of having high blood pressure. And then, as Dr. Anita stated, because this is February Black History Month, and we look at the statistics, y'all, for African Americans with high blood pressure, can anybody tell me what they think the percentage is for African Americans for blood pressure in the United States? Just put it in chat. Can anybody guess? Give me a number. 20%, 30%. What percentage do you guys think it is? Okay, we got 33%. Say anybody else. 35%. Okay, you guys are getting close. We need to go a little bit, 40%. Okay, a little bit higher. You guys, 55%. That's more than half. 60%, 55%. That's more than half of the population. Now, I have a problem with that. We all should have a problem with that, right? And so this discussion is going to allow us to brainstorm and think about what are some different components to addressing this issue. Like, how do we, as healthcare providers, as public health professionals, as health educators, what can we do? What can we do in our part, in the work that we're doing, to actually address these numbers? So But yeah, Dr. Anita, I wanted to be able to answer your question, and I apologize for keep talking on because I get excited about
And this is
hypertension, as
great.
you can see.
No, this is great. Let's keep the conversation going. That's right.
This is good. So did you have another slide, or did you want me to?
No, we do have another slide. Now, you mentioned earlier that it's always a good idea to use one machine, and that's very interesting because I've been in a situation whereby a client comes in, we take the blood pressure, right? And then it shows a different number. And she says, well, maybe that's not working. Let's use something else. Let's use another one. So she wanted to see a much lower number than she was showed before. So that's very interesting. You say that using a different machine. So tell me, why don't you explain to us, the irony behind using a different machine?
So I kind of sort of tapped into it a little bit earlier in reference to different calibrations. Different companies make different type of machines, but usually the machine that you want to use is the one that you probably would find in your physician's office. That's the machine type. It's the more expensive one, and I don't encourage day-to-day people to purchase those, but they can go to Walmart, CVS, any type, Walgreens. They actually have some that you can put on your wrist. Now, when you get those different types of ones, there's always room for debate. When you're looking at, people, researchers or physicians, they'll be like, no, use this one, no, use that one. So to your own discretion, find one that works for you. But the thing is, use that same one on a continuous basis, right? Because just like I talked about earlier, it's just like that scale that you have at your house. It's calibrated a certain way. So then you'll have a baseline number. You'll have that baseline number when you do your own home blood pressure monitoring. Then you track it, you write it down, and then you can check it every day. You can check it every other day. But again, I encourage you to do it in a place and at the same time, but also make sure you're in a place that's subdued. You don't want to be in a crowded room, because what can happen, it could hear the sounds of the surrounding to actually stop how it's calibrating your blood pressure. There's a lot of science behind because usually when you get it, like a nurse, they'll do it manually. So they'll have the stethoscope in their ear. They're listening for a beat, right? So now think about when you're out and about and you're using a machine, then any type of noise could skew your accurate reading. So usually this is evidence-based and best practices when it pertains to taking your blood pressure. So you usually want to sit in a dark, quiet room for at least 3 to 5 minutes, right? By yourself. All right, you'll have the blood pressure on, and at the point in time where you feel calm and collected and you feel good, you press that button and you get that reading. Okay, so that's going to be the most best practice reading for you to actually get when it pertains to doing your own home blood pressure monitoring. So making sure that your environment is cool, calm, and collective, because I know a lot of people say, my blood pressure is always high when I go to the hospital or when I go see my doctor, right? We call that the white coat syndrome. And so what does that mean? So like you get a little bit of anxiety, because now you're worried about, oh my God, what if I have high blood pressure and they're going to put me on medication? Oh my gosh. And so your nerves go up. And what happens when you get anxious? Your heart rate goes up a little bit too. And so there's some physiological things that happens when your body's adjusting to stress and trauma, right? Because in that moment in your mind, that, okay, this is stressful. This is stressful. So now it's like fight or flight. So let me figure out how I'm going to adjust to this. And so it could not be accurate to some degree. So that's why the whole blood pressure thing is always debatable. That's why I encourage patients or community members, hey, if you get a chance to get a blood pressure monitor on your own, grab it, monitor yourself, then you have a baseline. Then the thing that you want to do is make sure you get it down, keep a track of it, and then you'll see trends, right? And then you'll see like an average blood pressure. Then you take that note, you take that information to your physician. and then they will be able to see and have something consistent for you.
Yeah, I mean, these are all great. These are all great, points, and I like the fact that, you mentioned baseline. And I guess, that's the reason why, we have a lot of centers, like CVS has a center where you can actually the minute health minutes, where you actually go in there and take your blood pressure. Walmart has that. All these retail drugstores have that. So that's great, great. And especially for those who don't have machines at home. All right, so let's move on to the next slide here. All right, so the next slide talks about, the actual numbers. What are these numbers? And, because ethnicity is different, even within the Blacks, you have the African Americans, you have the African diaspora. So it's all different with all the competing priorities that it surrounds us, and the work-life competitions that we have. So what about these numbers? What can you tell us about these numbers here that's right in front of us?
Okay, so these are gold standard. These have been tested. This is the American Heart Association and American Stroke Association. I don't remember too, but mostly the American Heart Association. They actually adjusted it and changed it. I don't remember how long ago, but if you go into a physician's office and they your blood pressure and that top number is called systolic. If it's 120 and your diastolic, which is that bottom number, is 120 over 80, right? Then you are considered to have normal blood pressure. And so, of course, even with life, green means go, right? So when you at a light, the light turns green, that means go. So same thing concept here. So that means, okay, you're good to go. And so as those numbers get a little bit higher, that means, okay, let's slow down. Let's start looking and thinking about, okay, what am I currently doing why my blood pressure is a little elevated? And then as you slow down and then go into the orange, that's considered high blood pressure. But then there's like two different stages, right? And so as you get more into the red, bottom red, anything 180 over 120, usually if I see a patient in the community that has that number, we encourage them to go straight to the ER, because that number is extremely high, to the point where they could potentially have a stroke or have a heart attack or some type of heart failure. So again, it's very important to know these numbers, and also to stay within that. The green is always great to the yellow zone. That's fine, but there's things that you can do to get back into the green zone. Now, you do have some people that are just, I was just born this way and I just can't help it. I eat right. I run around and I have all this and I'm taking this and I'm taking that. So unfortunately, sometimes it can be passed down from genetics and genetic makeup. And that's to nobody's fault of your own family history, age. Men have higher risk factor for having higher blood pressure. But because of science and technology, there's ways that we're able to manage it. And it's called self-management, right? So there's different medications that you can be on. Some people don't want to be on medication. I've met some people that have been on medications, but they changed their lifestyle and actually they have gotten off of medication. But if you're a newly diagnosed hypertensive patient and this, like, oh my God, this is new for me, the best thing is just to first just say, okay, how did I get here? Like, does my mom, does my dad have high blood pressure? And like, how old am I? Think about those risk factors first, because they can contribute to why you do have blood pressure. Now, if you're thinking you're just like, okay, X to all of it. All right, so let me thinking about, what am I doing? Like, what type of, my lifestyle? Am I moving enough? Am I eating those healthy foods? Am I eating enough fruits and vegetables? Am I getting enough fiber? Am I getting enough fish oil, right? So a lot of different things, and there's a lot of different research when it pertains to food being medicine. And I'm a big advocate of making sure that we understand that food has medicinal purposes as well, right? Food can be beneficial to the body as well because we all need food to survive. But food has vitamins, nutrients, everything that our body needs for us to be able to function. Now, of course, with society, a lot of stuff is processed, and I'm not going to go down this road with this, but a lot of stuff is processed. So we have to be mindful of the foods that we're eating, because that could be, oh, look at you. This could be the contributing factor to having high blood pressure. And as the picture states, like dietary habits, like, am I eating a lot of processed foods? Am I not getting enough fruits and vegetables? Because I tell people I don't like condemning people for the foods that they eat, because at the end of the day, I like to have a cookie here and there. I like to eat some French fries every once in a while. But I always tell people we have to do stuff in moderation. So if I eat my French fries, let me make sure that I get some fruits in there as well. Let me make sure I get some fiber in there as well. Let me make sure I get some vegetables in there. But I don't make my French fries like my main course, right? So I have to think about moderation. So, and also as we look at the slide, making sure we're getting physical activity in, right? And so, and I don't like the word exercise, because when you hear exercise, they're just like, gotta sweat. Yeah. No, tell people, be physically active. And what does that look like for you? It looks different for everybody else. So like, I have 2 kids. Sometimes I like to go around and just hang out with them and run around outside. We just have a dance party. Some days I like to do it on my own. Like this morning, I got up, I dropped the kids off, and then I went to the gym, and I like to ride the bike. So I got on the bike and I did some cycling. So any type of thing, just taking a brisk walk, just raking the yard, just moving around, and just trying not to sit as much. And of course, smoking, and then making sure that those different type of risky behaviors could lead up to having us be prone for high blood pressure.
Yeah, Dr. Davis, and this is why this conversation has to be, continued, not just for this month alone. I've seen that a lot of times we are not aware of our bodies, and once your body tells you there's something wrong, listen to it. Here at CECG, we do have an initiative called Know Your Numbers. You talked about numbers, knowing those numbers, the upper number and the bottom number. So what we usually do, we tell our clients or community members that when you go to your doctor and the doctor comes back and tells you, well, the numbers are normal. What does normal look like? What do we understand by the word normal? So we always empower our clients that you need to know what normal is. What is normal for you is not necessarily normal for somebody else, because we're different. And you talk about also exercise. It's interesting, when the new year comes along, right? Everybody has a resolution. I'm going to lose weight. I'm going to exercise. However, no one wants to hear the word exercise because it's also intimidating. There's a little bit of a stigma towards that. So, let's get moving. Maybe, let's get moving. Let's try to adopt, words that are more gentle, that actually get people out. And with the dietary habits, that's a hard one for a lot of people. I mean, you and I have a very professional relationship whereby we talk about all the different barriers, especially the food deserts. That's where we find a lot of these issues. People who are really prone to be exposed or to become part of within the high blood pressure category. There's a lot of food deserts, bad eating habits, and whatever people can get on, whatever they can afford, you'll find that, it may end up being bad eating habits. Then we also have the work-life balance where we can't really balance, life and being at home and making that healthy meal. So life is always on the go, right?
Yeah.
It's always on the go. So we do have a lot of work to do, but again, it all depends on the individual and how you kind of design your life. I would say that. But this is
Yeah.
great, and please,
Yeah.
if you have any questions, put those questions in the chat. We'll come back to them. But let's move on. Thank you, Dr. Davis. We'll move on.
Mhm.
So why is there a disproportionate rate of high blood pressure overall?
I wish I had the answer for that. And I think there's a lot of questions when it pertains to, there's a lot of different factors to why there's a disproportionate amount of rate for high blood pressure, especially for the African American community. Because like we said, like the numbers are right there in reference to like 55% of Black adults have high blood pressures. But the interesting is like Blacks have the highest prevalence of hypertension in the US and are at the greatest risks of developing complications such as stroke, kidney disease, end-stage organ damage in comparison to other racial and ethnic groups. Although the Latinx reports lower rates of awareness, treatment, and control of hypertension, right? So you have the African Americans who are more prevalent for a lot of the complications due to hypertension. But then if you look at the statistics for the Latinx, they report lower rates of awareness, like being aware, treatment, and control of hypertension. And so my hypothesis when it comes to the Latinx, it could be the language gap in culture, and also even with the African Americans when it comes to blood pressure, and we're thinking about the culture of diet, right? I live in South Carolina, and in the South, I'm telling you guys, they deep fry everything. I'm talking about deep fried butter, deep fried cookies, deep fried, and they try to do healthy, like deep fry, like kale. But the reality is, thinking about the history of the journey of African Americans, right? Think about the added stress. Think of when our ancestors were on Africa. I'm gonna give you an example. Think you're home chilling in your house, feet kicked up. All of a sudden, somebody comes in your house and says, "Hey, what you're doing isn't right. Let me pull you out of your home and let me put you in my home. Everything that you had in your house wasn't right. Everything that you read, everything that you looked like, everything that you believed, the food that you ate, you know what? I'm just going to strip that away from you, and you're just going to come on over here with me to my house, and you're going to adapt, right?" So you have to look at it from that perspective of the journey of the African Americans and how there is such a lineage of added stress, displacement, prejudice, right? And discrimination. So just think about that anxiety, that added pressure, and that being carried down from one generation to the next. I tell you guys, that's just like, we're not too far removed from civil rights. I was talking to my mom the other day, and she was like, "Oh yeah, that's the school that we got segregated to." I'm like, "What?" My mom dealt with segregation. Just imagine what her mom dealt with. Just imagine what my grandmother's mom dealt with. So all of that is carried down from generation to generation. My grandma had to pray every day to say, when she released her son, to say, "I pray that he comes back." Could you imagine? "I pray that my son makes it back," because they lived in rural Virginia, where in that time they can just get snatched up by anybody, anywhere, and end up who knows where, right? So that is stress, and thinking about the discrimination of not having the right to vote, not having the right to be a complete person. So that could be a contributing factor to it. Also, the culture of food. Food is a centerpiece for a lot of the Black culture, because you know, you hear the whole concept of soul food. Like that was the point of, hey, you cook, your mom was to say, you cook from your hips and you put your foot in it, right? So that means you put all of yourself into it, because at the end of it all, even though outside of these walls, they don't like us, they don't love us, we're not considered people, I can bring my family together and we can be ourselves, right? And even if it's a type of food, it's a fried chicken, it's the collard greens with the pork in it, it's the sweet potato pies, it's not the healthiest foods, but it nurtures, it's nurturing, because a lot of people, especially from my grandmother's generation, a lot of people, they clung on to food. Like they cling on to, like, oh my gosh, we got to come together and we got to bring ourselves together for unity, for community, to feel like we're one with each other. Although we're still one with each other, but when we leave here, we might not feel like we're one with where we live at, if that makes any kind of sense.
It does. It's interesting you talk about the food, and I like, quite a few things that, you have, you've alluded on there. Now, from the African perspective, right, food is what actually, defines us, who we are. It's a culture. You look at the food and there's a culture in there. It's what gives us comfort, just like soul food. And there's a saying that if you want to get to know a person very well, meet them at the dinner table. That's when that's when you get to know them real well. And I remember one time facilitating a nutritional class. We're talking about palm oil, right? It's very tasty. If you've ever used palm oil in your cooking, in your food preparation, it's very tasty, gives a good taste, but also it's a dangerous ingredient. So when I tried to substitute it with something else, like olive oil, avocado oil, they did not really like that very well. That, you don't understand, palm oil is what defines us. It's tasty. I'm like, you know what? This is what it is. Of course, we have all these models that we're showing them. This is what it's going to do to your heart. I'm like, really? But how come our grandmothers, our grandfathers, ate this all these years and they're still living? I'm like, times were different. In today's society, we eat and we're in one place.
Exactly.
Back then, people ate, but they were moving. They were moving.
Exactly.
They were always on the go. So it's very different. And back again to these the barriers that we talk about, or disproportionate rates that we talk about. It is true. You find the access itself is a factor to some of these rates. Here in the United States, even, you're in South Carolina, here in the state of Maryland, we have some regions that are food deserts. The only grocery store you find is a mom and pop, where you can go get your fried chicken or your fried rice. You don't even get, fresh fruits and vegetables, Then there's also an issue of affordability. How are people able to afford the nutritious foods? It becomes a little bit, of a challenge, these rates. I think, to combat this or to reduce the overall burden of blood pressure is to really look at different factors. What we can control, what we can control, but also circumstantial factors, situational factors. And in this conversation is a wonderful conversation that really ties in with this, Black History Month. Thank you, Dr. Davis. All right, so let's move on. So what about the social determinants of health? We hear this all the time in public health. You and I have had this conversation several times. Community health, population health, everywhere is social determinants of health. So what can you tell us? So what can you share with the social determinants of health?
Yeah. So you really you tapped onto it a little bit, and I'm glad that you mentioned about access, right? Access to various things, access to have a better quality of life. So unfortunately, you might hear where you live can determine how long you live, right? Depending on your zip code. How sad is that? But it is facts. It is reality. I could just give an example. There is a zip code here, but if you go roughly where it's predominantly African Americans and it's lower income. But if you literally go 5 miles up the street, the life expectancy for that zip code is 10 years longer. Why? Now, let's look at this. In the lower income zip code, there's literally one grocery store. They did have 3, but 2 of them closed down, right? And so now they only have one access to a grocery store. And that literally is not within walking distance to a lot of the inner city community members. So what is left? You have Dollar Generals, you have mom and pop shops, right? And so granted, I give Dollar General, they're now accepting SNAP here in some Dollar Generals where they sell fresh fruits and vegetables. But then again, you know, a lot of the kids here now being raised on how to shop at the Dollar General versus learning how to shop at a grocery store, going down the aisles, being able to see different types of food selection, right? So just the fact of the zip code that you live in will determine how long you live. And as I stated, the example that I gave you guys, and like I said, if you drive about 2 or 3 miles up, 5 minutes away, it's a totally different community. They literally have probably like 4 grocery stores. There's 2 grocery stores right across the street from each other. Really, I mean, like, that really baffles me. Like, what is this about? And so that makes you ponder and it makes you wonder, like, is this strategic? Is there a strategy behind all of this? What is the theory? So if you think about, is the people that are able to create policies and laws to say this needs to be over here, are they thinking about those people that are impoverished and they're like struggling, not having access to a grocery store? And so it makes you retrain your brain on how you look at advocacy, right? So how do you look at advocacy? So am I advocating for, I always advocate for people, but now I'm in a different mindset of like, oh, let me talk to the person that can bring change on a larger scale, because advocacy is huge, you guys, in reference to signing bills, passing laws so that these leaders that we put in these seats to make sure that we're caring for people that they might even not even think about or see on a daily basis. So if the social determinants of health has just been utilized a lot lately, but the reality is it's always been here. And I say COVID has shed the light on a lot of stuff, you guys. COVID has taken the lens off of the public health and the healthcare eyes, because the reality is people that were underserved prior, they've always been underserved. They've always been in that situation. They've always lived in those projects. They've always not have access to food. They've always not have access to medication, right? So now when things slow down, and the government focuses a little bit more, they're like, oh my gosh, there has been an imbalance on a lot of things. Social injustice, there's been an imbalance on a lot. But for the people that have been on the receiving end for hundreds of years, we were just like, we've been trying to solve this. But you know what? Better late than never. But the reality is that the light has come on and light has been shed on these things, which is really good. And so like what I charge myself to do is continue to speak about it, to continue to advocate for it, because I will not do my grandparents and their grandparents and their grandparents an injustice of not being able to, because of them, I'm where I am at, because I'm fighting to continue to fight for the next generation. So it's very important to look at advocacy in a different way. And so that's how I look at advocacy in a different way. And I veered off your question, Dr. Anita. I apologize. But
No, I know, I know, but you know what? This is great. It's a great conversation, and because we have student interns on this call, I think it's important for them to understand, what this really means, because everybody reads social determinants of health. And like you say, it's always been here. Those people who we are talking about now, they're the same people who were not served back then. It's only that the pandemic really was the icing that really brought all public health up to light, that, you know what, we need to revisit this. And this time, let's make it a focus, and continue from there.
Sounds good.
Yeah, great. And if you, for those who are here, if you have any questions, please put them in the chat, as well as the different social determinants of health that you've come across, because there's a lot. Each region is different around the nation. Dr. Davis, you talked about the dollar stores, where folks actually go and do shopping. That really always baffled me, a lot, and now, because I'm more aware, even having been in this, area of education, I try as much as possible to go in different stores and actually see what they're selling, what's there, and compare it with all these other stores. It comes down to the consumer and health outcomes, because we know that, those big consumers don't want to put their, products in places where they can't make any profits. And that's one of the biggest problems as well. And when it comes to advocacy, so if we are advocating for better shopping centers, better shopping stores, we really need to really go to the consumers. We really need to go to our representatives and do this. So that's part of all public health.
Yeah, and like I said, and here we have, I tell you guys, we have a Dollar General on every corner, it seems as if, especially in different communities. But the beauty of the dollar store now is, the Dollar General, is that they actually, in some stores, in some locations, they have fresh fruits and fresh vegetables, where SNAP participants can actually use their card and get money back on it. So they have accommodated in some communities where, instead of not being able to have access to healthy fruits and vegetables, now they do have that access, and that's the step in the right direction, in reference when it comes to changing the culture of who we are. We have to advocate for the things that we want in our community, and also in our neighborhoods. And just think about, as I was looking at this image that you have on this slide, thinking about safe neighborhoods, walkable neighborhoods, bikeable neighborhoods. That takes work. That takes not me just saying, oh, I wish I could be able to walk here. That takes pulling people together. That takes putting a coalition together. That takes advocating and speaking to your local representative, or to the, to the congressman or whoever. Go to town hall meetings if you have to, and just advocate, and just be that annoying gnat in their ear, to say, oh, this woman is not going to let this thing die. No, we're not going to let this thing die, because our community needs it. Our children need it. Their children need it. So we're always we should, in public health, we should always be working for our children's children, that generation, because it takes years for change to come, and we've seen it. It takes years. So if we plant a seed today, and then that next generation continue to water it, then it'll sprout by the time that other generation gets there. And so the biggest thing, you guys, is just making sure that we plant a seed for change. That's what we want to do, is just make sure we plant seeds for change.
That's great. And when we talk about having some of these places where we can walk and bike. Now, in many regions of the country, they have this concept of live, work, and play, whereby, people live in the community, they work in the community, and they can actually play, which is a great concept. However, in that concept is only in areas where people can afford that type of lifestyle. It still is a problem, you know. So for those who are here, for the students who are here, I encourage you that anytime you are in an area, region, you know, be mindful, look around and see, because this is your field, you've chosen this field. Be mindful, look and see what can you learn, how can you be part of this movement, this public health movement, to change, to advance health equity. So with that said, you know, we do have about 14 minutes left. You know, why don't we dive into the questions? So we were able, and what I'll do is I will stop sharing my screen and then we can see everybody here. So Dr. Davis, some of the questions that were outsourced here, you know, from our live streamers, our loyal live streamers. The first question is, what are some obvious challenges with delivering culturally competent care?
Oh, that's a really good question. So if you guys look at the Census Bureau, right, for 2030, all of the baby boomers will be 65 years and older. And now let's look at the race for 2030. The white population will drop to 55%. It's currently at 59%. The Hispanic population is going to grow to 21%. It's currently at 18%. And then the Asian and the Black American population is also going to grow. So between now and 2030, whites will get smaller and minority race groups will keep getting bigger. So when we think about cultural competency in health, it initially referred to meeting people's needs from distinctive ethnic and racial groups. But now we also have to think about disability. We got to think about diverse socioeconomic backgrounds, members of the LGBTQ community. So culture and diversity has shifted, right? So some of the challenges to providing culturally competent care includes understanding and relating to the diversity, and I speak as patient from a healthcare perspective, patient populations. So for you, it could be a community member population. Think about, and we've talked about this, Dr. Anita talked about the lack of resources to provide culturally competent care. Also, biases and prejudices. We all have biases. I have biases. Every one of you have biases. For us, none of us have biases. Okay, but we all have biases. So culture, we talked about this, can influence treatment options. Like people, when how they determine what type of care they're going to get could be determined by their culture. How they look at health, what are their health beliefs, how they practice health. So as a healthcare professional, we have to display cultural competency, and by designing and providing programs and education and instruction that reflects the various cultures represented in various diverse communities, right? So understanding, communicating with, effectively interacting with peoples across different cultures. I tell students, you have to get out of your bubble. Your bubble is not the only bubble, right? There's a whole big world out there, you guys. Not everybody looks like you. Not everybody eats like you. Not everybody drinks like you. Not everybody dresses like, and not everybody thinks like you, right? And all of that stems from your culture. So to be a successful public health professional, it's very important to make sure you educate yourself, you read, you communicate, and you understand the different cultures. What motivates people to do what they do? Why do I wake up in the morning? I wake up in the morning first because I enjoy living. Second, I got 2 kids I got to provide for. Y'all, somebody on this call might not have kids. So your motivations are different than my motivations, right?
Yep.
So everybody motives and beliefs and decision makings are all different. And from a public health professional standpoint perspective, we have to be able to understand that.
I mean, I totally agree. Now, I like also to tie in the multicultural perspective, right? Now, we do have the culture, But then there's also that multicultural perspective. When we look at the census, the 2020 Census Bureau, we also saw that I think was 46% of the population identified being a mixed race background. So what does that tell us when it comes to culturally competent care? So now culturally competent care, multiculturally competent care, because you find household with how many ethnicities in there? Many. So, it really, tells us a lot as public health providers how to, tailor our education, our communication, even the literature we put out. So here at CECG, we have 7 different languages, and all our literature is actually translated in all these languages. Because when you look at the Capital Region, that's a DC District of Columbia, Maryland, Virginia, over 100 languages are spoken from all over the world. And my students know that I like to I like to call it the United Nations. So if you want the United Nations, come to the Capital Region. That's the United Nations. But anyway, we do have a few more minutes, and I know, Rethik, what are the questions that you are able to crowdsource? You want to unmute yourself and ask Dr. Davis?
Yeah, so the first one is, at what age should heart health screening be a standard routine?
I don't know the standardized regulation, but I know that when my child goes to the pediatrician, he gets his blood pressure done. I don't remember what age it is, because the reality is when we get over, and even at a young age, plaque starts to build up in our arteries. I do know that. It's not much, but that's when the plaque starts to build up. So I'm not going to say a specific age, because I'd rather be able to have that accurate data to give you that information. But just from my personal experience, I know my children. My daughter is 11 and my son is 8. I know they have gotten their blood pressure done while they've been at their provider's office.
Yeah, and that's also an action item for the interns. Look it up, interns. All right, what's the next question?
And the second question is, what are some of the gold standard programs to address high blood pressure / heart disease that you know of?
Some of the gold standard, I know there's a lot of research that have been disseminated and done by the American Heart Association and American Stroke Association. And one of them that comes to mind, which I actually had the opportunity of actually utilizing for our program, was called Check, Change, Control. And so the concept was they created an online portal where community members, it was the sample, the population was community members, getting them engaged in doing self-monitoring. Of course, research shows the more likely you self-monitor, then the more likely your blood pressure, you can manage your blood pressure, right? And so the premise was to get these community members in a safe place, in a safe environment, provide them with a tool and a resource to be able to track their blood pressure. So they were able to create an online software. They currently don't have it anymore, because we used to use it for our program, and it was called the Heart 360. And it was pretty innovative, where patients would actually go on and log in and create a portal, or create a profile. And then what they were able to do is they were able to input their blood pressure and keep track of it. And so from an educational intervention perspective, we would actually utilize our program. And when we met with them, we would provide them with the blood pressure. We would administer the blood pressure, and then we would assist them on uploading their blood pressure into the software. And so that really held them accountable. And a lot of them were able to use the portal to print it out. And some of the patients printed it out and they were able to hand it to their providers and the physicians. So I speak on the American Heart Association because they are the gold standard when it comes to anything dealing with heart disease. because they do a lot of scientific research. They are the go-to when it comes to me actually trying to pull data for any type of thing that deals with heart disease or stroke, because they're the gold standard for everything. But I was able to work with them to assist with the hypertension intervention program that we were administering at my location.
Great, great, that those are great questions, Rithik. There's one more question in the chat room, but before we get to that question, I also want to highlight some of the different on the ground initiatives that we do as a nonprofit. So here in the within our nonprofits and also in the Maryland region, we do have the barbershop, the beauty shop, initiatives where we actually go in and partner up with their, businesses, local business, minority-owned businesses, and do blood pressures like, Wellness Wednesdays, right? Do blood pressure checkups. We encourage, we share literature on blood pressures in different languages. We also have an initiative that we started many, many years ago. That was during my graduate days. It was a day labor initiative where actually we go to let's say Home Depot, right? When the day laborer is actually waiting for employers to come and pick them up. And there we had an opportunity to share literature on all health education. But the biggest was high blood pressure, awareness, because at that time it was reported that a lot of day laborers were actually, fainting on the job. There's a lot of stress and depression and all the other things that actually came with that. So there's a lot of initiative, and this depends on region by region. There's a lot of initiatives that people actually are doing. Now, when COVID hit, we know that, faith-based organizations were also on board in addressing all these disparities, access to all kinds of resources, and nowadays we also use community centers within neighborhoods where people live. So there's a lot of, minor little on the ground initiatives that are taking place. Now, to the question, and we see Mrs. Davenport has joined us, and this could probably be hers. So
did the meeting just start, or has it been going?
It's been going. It's almost ending. But
I thought it was at 12 o'clock.
We saved the best for last. That's okay. You're in the Midwest, so that's fine. So this question actually would be for you, Madam Chelsea. How do we incorporate movement exercise in the workplace?
Oh, that's great. Honestly, you can do anything from a chair. I am a yoga instructor and I teach chair yoga and any type of mobility in any capacity, because we all have different mobility flexibilities and then none. Some maybe just have they're not capable of moving like somebody like the younger. So chair exercises are great. We have in our school districts, because I'm the wellness coordinator for a school district, we have a lot of walking paths throughout the school. So just taking the teachers around in like a little kind of a trail kind of a situation inside the schools, if it's, if the weather's not good outside, on their little brain breaks that they take to get them moving more accessible around the schools. We have different type of challenges that, step challenge or walk with your colleague challenges. So just anything that can kind of get you up out of your chair to motivate you to move for heart health and all that. I'm so bummed that I came late because I really wanted to be a part of this conversation today.
Don't worry, we still have 2 more to go.
Yes.
Yes, but this is great, and Dr. Davis talked about a stigma that may be associated with exercise, because every time you talk about exercise, like, oh my God, everybody's going to see how much I weigh. But I like the fact that you can create your own challenge, your body challenges, step challenges, and good enough. Since this is Heart Health Month, our students are putting on Own It Challenge, which we'll share on our website, on our social media, on NWI, on everywhere. We'll share that. But anyhow, it's 1 o'clock, guys. I want to thank you so much for being here, Dr. Davies, Chelsea, for coming on for the few minutes. We'll love it. Everybody who's here, the students, the CECG staff, thank you so much. For those who are on our live stream, like us, send us many, many, many hearts of love. Okay. And this will be archived on our website as well as our YouTube channel. Thank you and have a good afternoon. Enjoy the rest of the day.
Thank you.
Thank you. Thank you very much. Bye.